All right, so in this lecture, we're going to talk about the coronary vessels and their relevant clinical pearls. So to start us out, we'll talk about the coronary circulation. Coronary arteries are medium arteries that provide the blood supply to the heart. And the highest level of blood flow in the coronary arteries is actually during diastole. That's a good fact to know. The coronary circulation, it begins at the aortic root, and you can see that here. So here's the aortic valve, and then here would be, around this way would be the aortic root, just where it's coming off the heart. And then you have the right coronary artery coming off here, as you can see. And then you have the left coronary artery coming off here. So they come right off the root of the aorta, and they branch immediately after the aortic valve. So if you look at a diagram here, kind of a different view of it, so you have your aortic valve like this. Just after that valve is when you're going to have the coronaries coming off like this. So this is a great diagram of the coronary arteries here. So the left coronary artery is actually a pretty short artery. It bifurcates while traveling under the left atrial appendage, and in fact, in the cadaver lab, if you look at the heart, that's a great anatomical landmark to help you find this artery. So because it comes off the root like this, and then it's very, very short, and then it immediately bifurcates into the LAD and then the left circumflex artery, which then wraps around to the posterior aspect of the heart. So the LAD, or the left anterior descending artery, it's a landmark for dividing the right and left ventricles. It runs right down the anterior surface, and you can see here. Sometimes it's also called the anterior interventricular artery. That's the same thing. So those are two names you to be aware of. And it comes off this bifurcation and runs inferiorly down the entire anterior surface. So what it supplies, this is very high yield to know. First, the anterior 2/3 of the interventricular septum. So the septum that separates the right from the left ventricle, the anterior 2/3 of that structure is supplied by the LAD. The anterior surface of the heart, so this portion right here, really, so this entire surface. And when we say surface and septum, we mean also the muscular aspect, the myocardium. Then also the anterolateral papillary muscle of the mitral valve, so that would be in this region right here. So one of those papillary muscles that's responsible for holding the mitral valve shut during isovolumetric contraction, so also very important. Left circumflex, so you have LAD coming down this way, and then left circumflex, as you can see here, is that other artery that branches off the bifurcation of the left coronary and then wraps around the posterior aspect. It runs in the coronary sulcus, which is a kind of a depression in the surface of the heart like this that is between the atria and the ventricles, and it wraps around to even the posterior aspect. You can also see it here as well. Here's the coronary sulcus, because here's the right atrium here, right ventricle, and here's that, again, that depression right here. Wraps around to the heart posteriorly all the way to the superior portion of the posterior interventricular sulcus. So if we look at the posterior aspect of the heart, there's again another depression on the surface between the left ventricle and the right ventricle, and the circumflex would come around from the anterior surface and then terminate just at the superior portion of that sulcus. So again, really important what it supplies: the lateral and posterior walls of the left ventricle, so the lateral part, posterior wall of left ventricle, the anterior lateral papillary muscle of the mitral valve, and then the SA node in the minority of people. So in the majority of people, the SA node is actually supplied by the right coronary artery, but in the minority of people, you can have actually SA node as well. So as you may have noticed on the previous two slides, the anterolateral papillary muscle for the mitral valve actually has a dual blood supply from the LAD and the left circumflex. And you can see that muscle right here. So you have the LAD coming down, that anterior surface. That's sending supply to it. And then you have the left circumflex wrapping around like this. That's sending supplies to it as well. And this is clinically important because, there's two papillary muscles for the mitral valve. There's the anterolateral, and then there's the posterior medial here in the back. The posterior medial actually only has one artery that supplies it, and it's usually the posterior descending artery, which we'll talk about in a few slides here. So what's important to know is, because if one of these arteries, let's say the LAD, has a blockage in it, this anterolateral papillary muscle is still going to get blood supply from the left circumflex. Versus for the posterior medial muscle, if the blood supply for that goes out, then there's nothing else to provide collateral circulation. And we'll talk more about that when we talk about myocardial infarctions in the clinical pearls section. So now the right coronary artery. So again, just like the left, it comes off the root of the aorta just past the valve here. And you can see it very nicely here coming down this way. And it supplies the right ventricle. It's the major supply for that. And it gives off branches to the major components of the cardiac conduction system in the majority of people. So in the SA node, it gives the SA nodal artery, so that's easy to remember enough, and then the AV nodal artery to the AV node. And this can be important because if you have an infarction in the right coronary artery and it's supplying the individual's SA node and AV node, that you can develop ischemia to these nodes, and that can throw the rhythm of the heart off, and affect the conduction system. It gives off the right marginal artery, which is a lower yield artery, but it's it's still good to know. It's one of the major ones you can still see, and you can see it coming off here and traveling this way, and it runs along the inferior border towards the apex, and so you can see here, and it aids the RCA in perfusing the right ventricle. So you can see it kind of extends out more this way to help totally cover the right ventricle. So the right coronary, this is a posterior view. So the right coronary wraps back around, and then as you can see, it dives down this way and gives this branch the posterior interventricular artery, which is also known as the posterior descending artery, or the PDA. And it descends between the two ventricles posteriorly, as you can see here. And this is really important. So it supplies the posterior 1/3. Remember, the LAD supplied the anterior 2/3 of that interventricular septum. The PDA supplies the posterior 1/3, the remaining. And then it also helps supply the left ventricle. It sends branches to the AV node as well. And then it also, what's important to know, like we were talking about, it's the sole arterial supply to that posterior medial papillary muscle of the mitral valve. So a blockage in the right coronary artery or in the posterior descending artery can actually affect that papillary muscle and actually even lead to mitral valve dysfunction. And that's a very high yield concept for the board exam. Some of the other papillary muscles, the anterior papillary muscle of the tricuspid valve receives a dual blood supply from the LAD and the RCA, so it's pretty well covered. And as you can see here, here's the anterior papillary muscle shown right here. So it receives, both from the right and the left. Posterior papillary muscle of the tricuspid valve, which would be back in here coming off the posterior aspect of the ventricle, is supplied by the PDA, the RCA, and the septal arteries as well. So it receives a lot of blood supply. And then the septal papillary muscle, which would come off the septum here for the tricuspid valve, is also supplied by the first, second, and third septal arteries. And one thing I want to point out, since we're talking about, is these septal arteries. So these are arteries in this case that are coming off the right coronary artery. So remember, the right coronary is kind of traveling this way, and it's giving off arteries that, in septal, it's just in the name, it's supplying that interventricular septum. And so that would make sense, especially for this septal papillary muscle, since these arteries are already traveling in this region, perfusing this septal wall. They're going to go on and to provide perfusion to the septal papillary muscle. So very briefly, the coronary veins. As far as a board exam, these aren't terribly high yield. These definitely could show up on an anatomy lab practical exam. So in a cadaver lab, you definitely want to ID these veins on the heart. There's three major veins. Obviously there's a ton of veins, but these are the three ones you want to be really aware of. So you have the great, the middle, and the small cardiac veins, and they all drain the heart and empty into the coronary sinus. You can see the coronary sinus labeled here. Here it is traveling right here. And it's the largest vein draining the heart. And as you can see, the great cardiac vein, which is coming around from the anterior surface, comes into it right here. And it lies on the posterior surface in that coronary sulcus, so that depression in the surface between the atria and the ventricles. And it empties right into the right atrium. And in the cadaver lab, you can even see this. If you cut open to the right atrium, you'll see the opening from the coronary sinus. You can even stick your probe through that and see it within the coronary sinus as well. So the great cardiac vein, we'll start here. This is the anterior surface. This is the posterior surface. So here's the great cardiac vein. Here's that anterior, so this is also the LAD. So important to know about the great cardiac vein is that it travels on the anterior surface with the LAD. It's almost like a highway. The LAD is coming out and going inferior, whereas the great cardiac vein is going the opposite direction, going superior. And so it's coming back up this way, and then it wraps around with the circumflex around the lateral aspect of the heart of the left ventricle, and you can actually see that here. Here it is traveling around with the circumflex artery, and then is where it eventually drains into the coronary sinus right here. The middle cardiac vein. So the middle cardiac vein is found on the posterior surface. It arises just with the PDA. It's going to travel in the opposite direction. So the PDA is going down inferior to provide the blood supply. The middle cardiac vein is actually draining all that blood supply and coming back up and goes straight into the coronary sinus. And it courses in that interventricular groove while it's on its way to drain into the coronary sinus. This is a common test question, especially on anatomy exams, is with these veins, is what artery do they travel in parallel with? So knowing that the middle cardiac travels in parallel with the PDA, and then that the great cardiac vein travels in parallel with the LAD, are two important facts to know. So the small cardiac vein, you can see it here again, starting on the anterior surface. Here's the posterior surface. It arises on the anterior surface of the right ventricle, and then it courses around the margin of the heart in parallel with the marginal artery. So you can see that here. Here's the vein. Again, the vein's going this way, the artery's going this way. So it comes back around and then it wraps around. And here you can see it labeled again. So it's wrapping around. And then it terminates posteriorly by draining into the coronary sinus, and you can see it. So as you can see, all roads, as far as veins go, lead to the coronary sinus. All right, so now that we've covered the anatomy of the coronary vessels, let's get into the clinical pearls. A lot of these are very high yield for anatomy exams, physiology exams, board exams. So this concept of right versus left dominant for the coronary circulation. And so this is a concept that definitely you could see on an anatomy exam, and you could definitely see it on a board exam as well. And what it's defined by is where the PDA, the posterior descending artery, originates. So here we go, also known as posterior interventricular, coming down the posterior surface. And now I know we said it comes off the right coronary artery, and it actually does in the majority of people. But there's also and that would be called right dominance, as we'll talk about. But in some people, it actually comes off of the left circumflex artery here. And so the reason that's important is because it determines whether the left coronary artery or the right coronary artery is the primary artery responsible for the blood supply to the interventricular septum. Okay, because remember how this artery supplies the posterior 1/3. So right dominance first. So in this is the majority of people. And the RCA gives off the PDA. So just like this diagram shows, the right coronary artery wraps around, and then it gives off the PDA traveling down like this. And it supplies the posterior 1/3 of the interventricular septum and the posterior region of the left ventricle. So this portion right here, which is also important because the left ventricle is the main pumping chamber of the heart. It's responsible for getting the blood to the systemic circulation. And so a blockage affecting the artery supplying any region of the left ventricle is very significant. So left dominance, this is where the left circumflex artery gives off the PDA. So you can see the circumflex here. And that would be like if this artery were to keep continuing on like this and then give off the PDA like this. Okay, so that's what it would look like. And then so the left coronary artery or the left circumflex would be responsible for supplying the posterior 1/3 of the interventricular septum, and actually the posterior area of the right ventricle. So it would be responsible for supplying this area as well. So the majority of the people is right dominant. Now and then the rest of the people is kind of a split between left dominance and then codominance. So in these individuals, the PDA actually arises from both the right coronary artery and the left circumflex. So you can see it coming in here from the right. So again, the left would come in like this and supply it like this. So you would essentially have two feeders to the PDA. So if we draw the PDA like this, it's going to have one feeder from the left circumflex, and then it's going to have another feeder from the right coronary. And so for these people, the blood supply for the posterior region of both ventricles is dependent on their respective main arteries. So the posterior region of the right ventricle is dependent on the right coronary artery, and then the posterior region of the left ventricle is provided by the left coronary artery. So the course of coronary flow, this is just a good anatomical fact to understand, and actually helps you understand some pathophysiological concepts as well. So we'll talk about it briefly. So here's our layers of the heart. Here's a snapshot of it. Here's your endocardium, the inner layer, the myocardium, the muscular layer, and then you have the epicardium out here, which is the outermost layer. What's important to know is actually that the coronary vessels travel in the epicardium like this. Okay, so when you see these vessels on the surface of the heart, what they're actually doing is traveling in the epicardium. And they give off these smaller branches that course down through the layers of the heart. So the heart is supplied from outside to in. That's how the blood flow will travel. So the blood travels in through here, and then it makes its way down to the deeper surface. So the last layer, the endocardium, is the last to get supplied. And that's true because you keep sending these feeder arteries down. And so the order goes, epicardium, myocardium, and then endocardium. And because of that, the endocardium is actually the first to undergo ischemia during a myocardial infarction. Because if you have a blockage, say right here, say you have a huge blockage right here, the last to get the supply is the endocardium. It's the furthest from. So you're going to still have that last bit of blood that's getting through here. It's going to make it, to the epicardium and then maybe into part of the myocardium. but it's just not going to make it all the way down to this endocardium. So that's why it's the first to undergo ischemia. And so this ischemia to the endocardium actually leads to what's called subendocardial necrosis. And this is when there's a significant restriction in blood flow. And it occurs because it's the last layer, like we said, to receive blood supply from the coronary vessels. And so it's this endocardium and kind of this sub, area right here, the subendocardial. And on the EKG, this is important to know, especially for exams. So you have your EKG, you have, your P wave, and then you have your Q, R, S. So Q, your R, and your S. And then you have your T wave like this. So you have actually a depression in the ST segment. So from here to here, you'll see kind of a depression on the EKG, and that can be indicative of subendocardial necrosis. Versus on the next slide, we'll talk about transmural necrosis, which is where the entire wall is ischemic and necrotic. That actually leads to ST elevation. So it often occurs due to an infarction in the proximal part of the blood supply to the area. So, blood supply more proximal versus, down here, because, again, it just takes longer for the blood to get down here. And so this is going to be the last to receive it. So that's what puts it at the most risk. So subendocardial necrosis, it can also occur due to physical compression of the blood supply to the area. An example of this is hypertrophic ventricle due to aortic stenosis. So like we said, when the aortic valve is stenotic, it's a much higher resistance for the ventricle to overcome. So the ventricle has to, work harder and becomes hypertrophic. And so it actually compresses. And so, if you have the wall of the ventricle like this and it gets larger and larger and it gets thicker, the blood vessels running through the wall like this, they're going to get compressed because it's, there's just only so much space. And so if it's getting thicker and compresses, the blood supply coming through here is going to get affected. So how does that translate? So say, this part, here's, a blood vessel here, and it's getting compressed by a thicker, muscle here and here. So this region of the myocardium is the first, and so it's not going to be as affected. It's it's going to be limited in blood supply, but it's not going to be as affected. And then you get down to maybe this section, and that's going to be more affected. And then the worst is going to be, this subendocardial region right here, because it's the last to receive the blood supply. It's almost like the blood supply runs out. So transmural necrosis, this occurs if ischemia continues for a long enough period, or if the infarction is severe enough to affect the entire wall of the heart. So that would result in transmural necrosis. It involves necrosis of all three layers. So not just this endocardial layer, it's necrosis across this entire region here. So if this region is supplied by a vessel, it'd be this whole region is knocked out, okay? Is ischemic and begins to develop necrosis. So on EKG, this segment, you're going to see an elevation. So ST segment elevation, or STEMI. You may have heard that term. STEMI means ST elevation, myocardial infarction. This is incredibly serious. And as you can imagine, it makes sense because, it's versus subendocardial, where it's only maybe this region that's, ischemic and developing necrosis. This an entire region of the wall of the heart is becoming ischemic and necrotic. That is a significant MI, which can lead to death very quickly. So these patients that come in with a STEMI, these are the kind of patients where you hear about in the middle of the night, the cardiologist is coming in the middle of the night and taking them to the cath lab and fixing them right away. So angina, this is chest pain that results from underlying atherosclerosis in the coronary vessels, and it progresses to the point where it limits perfusion to the myocardium. So you have that epicardium here, and then you have the myocardium here, and so here the vessels are coming in and beginning to develop narrowing of the lumen here due to plaque. The flow is still getting through, but it's progressed to a point where even the myocardium is beginning to experience some limited perfusion, and that's what gives you angina. And as you can notice here, here's a nice open, clean vessel, versus here where you have this plaque developing here, this atherosclerotic plaque. It's limiting blood flow. The lumen's much more narrow. As you narrow the lumen, you're going to decrease the blood flow. So you have decreased blood flow coming through here, and that's what leads to your angina. Now, what's important to know is that the key difference compared to a myocardial infarction is this is actually reversible. This is reversible injury, so it's not permanent damage to the wall of the myocardium, and that can be achieved with lifestyle changes such as such as losing weight, quitting smoking, eating better, stuff like that. And then drug therapy, so statin drugs that can lower your cholesterol, blood pressure medications, and then or angioplasty. So some people, they get angina, they come in, it's severe enough, you got to put a stent in here and open this vessel up. Usually this pain is relieved by nitroglycerin. And the reason why, this is an important kind of side concept, nitroglycerin, you would think, oh, maybe because it dilates the vessels. The problem is the vessels are blocked. The reason nitroglycerin actually relieves chest pain is it decreases the work on the heart, because it actually decreases resistance in the systemic circulation. So it decreases systemic resistance, SR. And by doing that, you actually decrease the work of the heart. And if you get real into physiology, if you're doing this would be, decreased afterload. So you decrease the work or the afterload of the heart, and with that, and just like anything else, if you lift up a 10-pound dumbbell versus a 20-pound, that's a lot less work. Your muscles stressed a lot less if you do lift the 10 versus the 20. Same concept here. You're decreasing the work so the heart doesn't have to work as hard. And that's why, and so by decreasing the amount of work, you decrease the amount of oxygen needed. And so it doesn't matter as much that the myocardium isn't getting enough oxygen, enough perfusion. It's still important, but since it's not getting stressed as much, it doesn't need as much oxygen. And so that's why the pain is relieved by nitroglycerin. So there's 3 types of angina. There's stable angina, which is chest pain that occurs only during exertion, and it's relieved by rest. So that same kind of concept, when you put more work on the heart, so during exertion, walking upstairs, running, those types of things. Things where you need the heart to pump harder and faster, and when it pumps harder and faster, it needs more oxygen. And so when it needs more oxygen, if you have a limited blood flow, you're going to feel it. And so that's why, versus a normal person, someone needs more oxygen, you just get more blood flow. It doesn't matter. There's plenty of blood flow to go around. You're not going to, but versus where no matter how much the vessel dilates, there's still this blockage. There's still cutting off blood supply. And then when you rest, you decrease the work on the heart, just like how the nitroglycerin does. Decrease the work on the heart, decrease the need for oxygen, the amount of oxygen that's needed by the myocardium, and then the pain is relieved. Unstable angina is chest pain that occurs while resting, and it has a high risk of progressing to myocardial infarction. So it's usually unstable is much more significant blockage, and so it doesn't matter. Even while you're resting, you still feel the chest pain, and because even the small demand of resting still demands oxygen, and if the blood vessel is occluded so much that such a limited amount of blood flow is getting to the myocardium, even when it's resting, it's still not enough oxygen. So as you get it gives you a clue of how little blood flow is really getting to the myocardium in these patients, and that's why they have such a high risk of progressing to myocardial infarction, because eventually that could block off, and then you don't really get any blood flow, and then that's what ends up leading to ischemia and necrosis. Prinzmetal angina, this is episodic chest pain, so it's it happens not necessarily for any particular reason versus resting versus exertion. It's more due to coronary vasospasms. And so, if you remember, you have this tunica media in the vessel, this muscular layer. So it's just muscle spasms, vasospasms, just muscle spasms of the tunica media. And so, the tunica media contracts, and then they compress the lumen like this and make it smaller. And then that cuts off blood flow. And then, the myocardium feels that because it's less blood flow, less oxygen. That's where you develop ischemia, and then you get your chest pain from that. So a myocardial infarction is really the next step in this pathogenesis. It's the atherosclerotic plaque builds up over time in the tunica intima. So again, you have that, that's just below the endothelium. So you have the endothelial cells like this, the intima's in here, you have a plaque building up in here, you have your blood flow going through here. This, pushes up on the wall, and over time this plaque develops and develops and develops, and it's filled with, lipids. And then it has a fibrous kind of connective tissue cap that goes over it like this. So it has this, thick, fibrous connective tissue cap. Now, the basic pathogenesis, we won't, again, this isn't a pathology course or physiology, but, just to give you the basics, is that you have a rupture of this atherosclerotic plaque. So this ruptures, it's almost like a, a balloon or a case of, lipids. It breaks and it creates a thrombosis within the coronary arteries. So if this were to rupture like this, it ends up, all the contents leak out and it creates a thrombosis right in this vessel here. And that's what blocks blood flow, and then, obviously cuts off blood supply to the region of the heart that is, supplied by this artery. Presentation: severe crushing chest pain that radiates to the left arm. And in some cases, this is due to that intercostobrachial nerve because it shares the same spinal nerve roots as the cardiac nerves. So you have the intercostobrachial coming in from here. You have the cardiac nerves coming in like this. And then they come into the same root into the spinal cord. And the brain can't really tell the difference. So that's why you can feel this pain coming out along this nerve out into the arm. And so that's what explains that. It can also radiate to the jaw. The treatment, the acronym's MONA, so morphine for pain control, oxygen, nitroglycerin, like we talked about, decrease the workload on the heart, and then aspirin to help prevent any clotting. Then, obviously if it's a STEMI, you're going to go right away and do angioplasty. You're eventually going to do angioplasty anyway. And then if it's bad enough, if they're significant, or if it's in the anatomy is difficult to do angioplasty, then you do coronary artery bypass grafting or cabbage surgery. All right, so now that we've gone through the basic pathogenesis of a myocardial infarction, now we want to talk about some high-yield facts for anatomy exams, board exams. And so what we've compiled here is a table, and this is in your book, so first is the surface of the heart that's affected. So there's different surfaces, the anterior surface, the posterior surface, the diaphragmatic surface, because it rests, down this part right here is going to rest on the diaphragm, the lateral surface, so this part out here. And so you'll get test questions on this where you'll say it'll be an anterior MI or a posterior MI, or a diaphragmatic surface is the most affected by this MI. And you'll get asked what artery was most likely. Now remember, these exams, especially board exams and typically medical school professor exams as well, the most likely, so it's not it's what is the highest percentage. They're not asking, it's very rarely is it, one artery that's the cause all the time, 100% of the time. So for the anterior surface, the major artery supplying the anterior surface of the heart is the LAD. And so the answer would be LAD. Yes, are there other arteries that supply the anterior surface? Yes, but the major one is the LAD. So if you have an MI that affects the anterior surface of the heart, the most likely artery that's going to be affected is the LAD. Posterior surface is going to be the right coronary or the left circumflex artery, and this probably has a little bit to do with whether they're right or left dominant. If they're right dominant, it's going to be the RCA. If they're left dominant, it's going to be the circumflex. And so you can see that here. Here's the right coronary coming around, and this would be your posterior surface. Here's the left circumflex coming around here, this posterior surface as well. Diaphragmatic surface is going to be that posterior descending artery right here. So coming down here, this is going to be your diaphragmatic surface, the part that actually rests on the diaphragm, that dome-shaped muscle. Then you have the lateral surface, which is going to be this circumflex artery, which makes sense because it's wrapping around the lateral aspect of the heart. If you remember, the heart in the chest is more situated to the left side. So this is the part that's more situated to the left. That makes sense that it's the lateral surface. This would be more so the medial surface. Again, now we're going to talk about some, physiological effects that'll happen in MIs and which coronary artery is most likely to be affected. So the right ventricle is primarily supplied by the right coronary artery. So if an MI causes right ventricular failure, the most likely culprit is the right coronary artery, which makes sense. It's coming out here and it's supplying this whole aspect. Left ventricular failure, most likely is the LAD, because the LAD is the major blood supply. Even in someone who's right dominant, which is the majority of people, even though they're right dominant, remember, right dominance doesn't really have much to do with the anterior surface or really the majority of the blood supply to the left ventricle. And the left ventricle is the most important because it's supplying the systemic circulation. So even in someone who's right dominant, the LAD is still the most likely artery that is going to be responsible for a heart attack that caused left ventricular failure. Atrial dysfunction is going to be the right coronary artery. So a myocardial infarction that leads to mitral valve regurgitation is a very high yield concept, especially for board exams. It's very likely you'll see this in a Q bank, on a practice exam, and then even in the real thing. So what you want to be aware of is, so you have this anterior lateral papillary muscle. So we'll call this ALM, okay? ALPM, papillary muscle. Then you have down here, you have the PM, so posterior medial papillary muscle, okay? And then this is supplied by the PDA. And then this is supplied by the LAD, the left circumflex. Okay, so this is the anterior lateral muscle has a dual blood supply. The posterior medial muscle has a single blood supply from the PDA. Okay, and so a typical question would be is, oh, patient has an MI, then they're treated for the MI, and then they develop a murmur. And usually they don't tell you it's mitral regurgitation. Usually you have to figure out that, they'll say it's a systolic murmur heard at the apex of the heart, which would be a mitral regurgitant murmur. And so you determine its mitral regurgitation from what they tell you about the murmur. And then they're going to ask you which artery was most likely affected by this MI. And, they'll list, LAD and left circumflex and right coronary artery and, whatever else. And so they're going to ask you which is the most likely. Now, if you look, the anterior lateral muscle is supplied by both of these. So theoretically, yes, a blockage in either of these or in the left coronary could affect these. The problem is if you knock this out, you still have the left circumflex supplying it. So it's not as likely. It's not likely you're going to have both of these arteries knocked out, okay? And so what it's more likely is that the right coronary artery had an infarction, cuts off blood supply to this posterior descending artery, and then it blocks off the only blood supply to this posterior medial papillary muscle for the mitral valve. And so by doing that, by killing off this muscle, you develop mitral valve dysfunction and mitral valve regurgitation. So again, just to review this very quickly, right coronary artery, it wraps around, gives off the PDA on the posterior surface. That supplies this posterior medial muscle. It's the only blood supply. You cut off the right coronary, you lose this blood supply to this muscle. It's affected, and then you develop mitral valve dysfunction. This muscle has a dual blood supply, so it's not as likely as the right coronary. So again, just to drive that home because it's so high yield and important to know. So cardiac conduction abnormalities. So if they have an MI and then as a result they develop cardiac conduction abnormalities, so some change in the rhythm, the rate of the heart or the rhythm of the heart, something going on with the electrical conduction system, the most likely, and they could ask you, what's the most likely artery affected? The most likely is going to be the RCA because the right coronary supplies the SA node, which is up here, that SA nodal artery to the SA node. It also, in most people, it provides the AV nodal artery to the AV node. Again, so it's what's most likely. What is most people's anatomy? Most people's anatomy is that these two nodes are supplied by the right coronary artery. So if someone develops, electrical conduction failure or abnormalities, it's most likely that the right coronary artery was affected. All right, and that closes out our discussion of the coronary vessels and their relevant clinical pearls. It really closes out our entire discussion of the heart. Next, Anthony's going to talk to you about the breast section.